All right, good morning, everyone. Thank you for those who are here in person. Once again, as usual, we really appreciate it. It really means a lot to the speakers who took their time to do this and come here today. So this is one of the last grand rounds of the year, and we're have two of this year's chief presidents, and Jonah Graves and Sarah LoCoco. Jonah is going to start us off. He hails from the great state of Missouri/Kansas-ish border, and he's heading to Pulmonary Critical Care Fellowship next year, or in a few weeks actually. So he'll be here. You'll all be able to see him in just a few weeks. And he's going to give us a talk on the cost-conscious care and the carbon footprint of medicine. And then followed by Dr. Sarah LoCoco from Texas, who's going to be staying here for a cardiology fellowship, as her talk, aptly implies, talking about machine learning and white complex tachycardias. So we'll give it away to Dr. Graves.
Thanks, Stephanie, and thank you everybody for being here this morning and for giving me the opportunity to talk on this topic that I've become pretty passionate about. Can you all hear me? I'll turn this on, I think. So as Stephanie mentioned, my name is Jonah Graves. I'm one of the chief medicine residents here at WashU, and I've had the privilege of being the ambulatory chief resident this year. Happy to be here today talking. The title of my talk is Healthcare's Carbon Footprint, Redefining Cost-Conscious Care. I hope over the next 25 minutes or so, I can relay an understanding of the impact the healthcare industry and the health sector has on the climate and what we can do to mitigate that. Before proceeding, I don't have any relevant financial disclosures. So today's talk is really part one of two, exploring the relationship between the climate and human health and healthcare. As mentioned, I'm going to be talking about the impact that healthcare and healthcare delivery has on the climate. And next week, my co-chief and colleague, Dr. Puya Jolharzadeh, will be talking about the inverse of that, which is the impact that the climate has on human health and will have over the next century. So the learning objectives today are three. The first is kind of to go over the current state of the climate and projections for the next century in terms of both temperature and carbon dioxide emissions. Then we'll transition to talking about the health sector's climate footprint and the impact that we have as a healthcare system and as a sector on the environment around us. And lastly, we'll talk about mitigation strategies and ways that we can limit our impact on the environment. So it should come as no surprise to anybody here that global temperatures have been rising consistently since 1950. And the two hottest years on record were both 2016 and 2020, with a rise of greater than 1 degree centigrade, that of pre-industrial surface temperatures. And temperatures are projected to rise, throughout the century, basically no matter what we do. And this phenomenon is the direct result of this, which is rising atmospheric concentrations of carbon dioxide. And atmospheric CO2 levels rose starting around the industrial era and have skyrocketed essentially since around the 1950s. And right now they sit about 50% higher than they were in the pre-industrial period. And currently the atmospheric CO2 levels are 421 parts per million, whereas about 30 years ago, they were closer to 370, 360, and 30 years prior to that, they're around 320. Now, the Intergovernmental Panel on Climate Change, which is an intergovernmental body of scientists and policymakers, has urged the global community to limit global warming to 1.5 degrees centigrade and, at a minimum 2 degrees centigrade in order to stave off the worst consequences of climate change, that being devastating floods, droughts, famine, and mass migration. And these are all things that we're already dealing with now, but those would be revved up to a degree that we can't even imagine. And to do that, we're going to need drastic, steep cuts in greenhouse gas emissions over the next 50 years in order to make that happen. And the world came together in 2015 at the Paris Climate Agreement to limit emissions and to move toward a net zero emission economy by 2050 in order to limit global warming to 1.5 degrees centigrade. However, subsequently, policies that were implemented will not get us there. And as you can see outlined in this IPCC report, currently implemented policies will essentially level off emissions over the next 50 to 100 years and will not get us anywhere near where we need to be. And in order to limit global warming to 1.5 degrees or 2 degrees Celsius, we need drastic, steep cuts that sort of follow this trajectory here. So I'll have to say we're not in a good place and we need urgent action now. to prevent devastating global warming. So where do we fit in as healthcare providers, as physicians, as a health sector? Well, it turns out we contribute a lot to this problem. The global the health sector's greenhouse gas emissions, or emissions that come from what we do, accounts for about 4.5% of global net emissions, which doesn't sound like a lot on the surface, but when you look more closely at industrialized nations and nations with more modern health systems, those numbers get a lot worse, as we'll talk about in a minute. Now, not surprisingly, the United States leads the world in health sector related greenhouse gas emissions, and it's followed by China and the European Union, as outlined here. However, when you look at greenhouse gas emissions from the health sector per capita, we look a lot worse than everybody else. The United States is up here at the very top with a very large amount of emissions per capita, whereas China, which comes in second in the world, is actually way down here at the bottom. So we have a serious problem in the United States in terms of the amount of greenhouse gases we emit in order to take care of patients. And the proportion of greenhouse gas emissions that stem from the health sector within the United States rose after 2000. And the most recent data available from 2013 says that about 10% of all emissions in the United States comes from the health sector. And that's pretty substantial considering the global amount of emissions that we produce in the United States. And in fact, if the United States health sector was a nation, it'd be the 13th highest emitter in the world and would emit more greenhouse gases than the entirety of the United Kingdom. So, and again, all that to say, we have a pretty big problem. And that probably comes as no surprise to anybody here because we've all worked here, right? And we get how wasteful and not environmentally friendly our industry is, right? We've all seen the endless amounts of single-use plastic. We've all used endless amounts of electricity and power to take care of patients. And some of that is a reasonable expense that we all would agree on. We need to take care of patients. We need power and electricity to use machines and equipment. We need a certain amount of plastic to take care of patients safely and in a sterile and aseptic way. Interestingly, a study that was actually performed here at Barnes by Dr. Jason Burnham and Dr. Maren Coliff, as well as colleagues in a hospital in Australia, quantified the amount of carbon it would take to take care of a patient with septic shock in the ICU, as well as single-use plastic. They performed a life cycle assessment from the start to the end of all of these products, taking care of patients and then to their final destination. And what they found was the amount of electricity needed to take care of a single patient in the ICU every day with septic shock was about 124 kilowatt hours, which is the equivalent of about 6 gallons of gasoline. And similarly, the natural gas used to essentially heat the ICU was about half a gigajoule, which is equivalent to 148 kilowatt hours or 7 gallons of gas. Added on top of that, each patient required about 270 grams of synthetic rubber, 2,500 grams of non-PVC plastic, and 560 grams of PVC plastic, or in total greater than 3 kilograms of single-use plastic every single day. And then start multiplying that by the fact that we have 34 ICU beds that are open 24 hours a day, 365 days a year, along with multiple ICUs, and then 1,000 patients, or well over 1,000 patients in this hospital at any given time. This problem gets pretty substantial. Unfortunately, though, as bad as that may seem, that only accounts for about 30% of all health-related emissions, which is purchased energy, the electricity, the gas, the heat, the steam, and the direct emissions that come from health facilities and vehicles owned by health systems and health facilities. The remaining 70% of all emissions that come from the health sector come from the supply chain. Everything it takes to produce all the single-use plastics, the pharmaceuticals, the equipment, and as well as grow all the food that's needed to feed well over 1,000 patients 3 times a day at this hospital alone, packaged up in another country, shipped across the ocean, put onto a truck or a train, shipped here. All of that, it accounts for really 70% of all health sector related emissions. And so even though what we do seems profound and incredibly wasteful, that doesn't even begin to address the scale at which we emit greenhouse gases into the atmosphere. So what can we do? I mean, this is a profound problem and profoundly more complicated in the political context of our country. And but there are some things we can do, and I've outlined a few here. The first thing I think we need to do is expand how we define and teach about the cost of care, and that's kind of what I refer to in my title of this talk, which is we need to go beyond just the dollars and cents of providing care and to consider the environmental and other downstream consequences and costs of our care. Second, we just need to reduce healthcare utilization and reduce the amount that we're doing. And this is something we're already doing to save patients money and wasteful care, but we need to extend the reason as to why we're doing that. And lastly, we really need to advocate for cleaner energy sources, a cleaner purchasing practices, and a cleaner supply chain in order to really get at that 70% of all emissions and reduce our impact. So diving into that a little bit more, we're all probably familiar with the Choosing Wisely campaign. This comes out of the ABIM and is an urging of specialties to identify, a top 5 list, which is things that lack evidence and should be, considered more in depth than before using in order to serve as basically a prescription for how the most money can be saved the most quickly without depriving of any patient of meaningful medical benefit. But this definition, for the most part, focuses on the financial cost of providing care, and it also considers harm that can be done to patients with testing and procedures that aren't necessary. But as I mentioned, we really need to expand that and include greenhouse gas emissions or environmental toxicity into this definition, because what we do requires more cost than just financial dollars and cents. There is an environmental cost to everything we do, and we need to include that in the definition of how we define cost and how we define cost-conscious care. And then on the education side, we need to teach about these things. We currently don't. I just finished a residency program in a medical school curriculum that really did not place much of an emphasis on the environmental cost of what we do. There was a great emphasis and a great education on the financial cost of what we do, and there was an emphasis on providing cost-conscious care. But we need to expand that and to include environmental toxicity in this. And this is something that the ACGME already requires the residency programs. We just need to build it up a little bit and expand what it means to pay for care. I mentioned we do need to reduce healthcare utilization, and it goes without saying that fewer hospital days begets fewer emissions, fewer diagnostic tests and procedures begets fewer emissions. And this gets back to an emphasis on choosing wisely and limiting tests and procedures that provide little benefit to patients, choosing things wisely, and providing a cost-conscious care to patients, again, with the environment in mind. And then we need to transform how we provide care too. So not only limiting care, but transforming the venue of care and doing things like reducing inter-hospital transfers using teleconsultation. And if you can take care of patients who've had strokes at hospitals without moving them to a more centralized location, you can take care of patients in an ICU through telecritical care without transferring them to a central location. That limits the greenhouse gases required to transfer patients and go through that process. Similarly, in the outpatient context, reducing outpatient appointments not only saves patients the time and hassle of traveling, but it limits the amount of resources it takes and the carbon it takes to get them there. So what about advocacy? I mean, it is needed at both the hospital level and the national level, and I'll go through a few examples of each and how we can have an impact as a healthcare system and as a society of physicians. The first is at the hospital level. Hospitals that have been successful at advocating for environmentally cost-conscious care have implemented multidisciplinary green teams or green committees that involve all stakeholders in this process, and from physicians to pharmacists to nurses to custodial staff and techs, and anybody, everybody that works here can probably identify waste in their area. And these teams should be performing audits of energy usage and figuring out ways to turn off wasteful consumption of energy. And they should be reviewing and revising purchasing practices and putting an emphasis on purchasing reusable and biodegradable options as opposed to single-use plastic, and focusing on choosing greener formulary preferences, which I'll talk about here in a second, in order to limit an individual hospital's impact on climate. And you do that with a few hospitals, and the impact starts to get pretty big. Couple of examples of formulary changes that can really profoundly reduce a hospital's carbon footprint. One has to do with anesthetic gases. So anesthetic gases are themselves potent greenhouse gases, and at a lot of hospitals, they're exhausted straight up through the ceiling into the atmosphere. They're not equally potent though. So desflurane is actually 20 times more potent than sevoflurane. And in a lot of situations, one can be used interchangeably with the other. And for this reason, actually in the UK, 40 National Health Service organizations have actually phased out the use of desflurane simply because of its global warming potential. And that's something that can be done here probably relatively easily in the United States. So one that hits closer to home as I'm going into pulmonology, meter dose inhalers use hydrofluorocarbons as propellants, which are incredibly potent greenhouse gases and are 2,000 times more potent than carbon dioxide. And one estimate, this seems amazing, but one estimate says that 0.5% of the global health emissions across the world stem solely from meter dose inhalers because they are that potent. And an easy fix for that is to just transition to dry powder formulations, on a formulary, because in most patients and most situations, providers could probably pick one over the other and it wouldn't make much of a difference. And obviously you do need to provide care that's indicated for patients, and some patients are going to need meter dose inhalers, but limiting their use can have a profound impact on how we impact the environment. So at the national level, it's hard to imagine what we can do in this country to advocate for actionable change at the national level. But one example to follow is at the National Health Service, and I've already referenced them in this talk. So in the United Kingdom, the NHS has set 2 targets aiming to have a net zero carbon emissions before 2050 as an entire system, and they have two goals. So for their direct emissions and purchased energy, which I previously mentioned accounts for about 30% of all emissions, they're aiming to be net zero by 2040. And they're already working on this by overhauling healthcare facilities and transport vehicles owned by the NHS. And as of 2021, the NHS was purchasing 100% renewable energy in order to meet this goal. Now, the supply chain is a lot more complicated. There's a lot more stakeholders involved, and it's harder to track and account for all of the emissions that go into the supply chain, but they are aiming for a net zero supply chain by 2045. And the NHS has a lot of bargaining power, right? It's a single payer system, and they can use contractual agreements to enforce decarbonization on the supplier side. But they're also reducing single-use equipment and going through a multitude of other steps to reduce their supply chain emissions. And ultimately, this is our trajectory here, which is on a pretty steep downward slope. And ideally by 2040, 2050, they're going to be at net zero. And this graph really just goes to show that the cuts are being made across the board and not in any one particular area, but they're decarbonizing their electric grid. They are shifting their inhaler types. They're shifting their anesthetic gases. They're building more energy efficient buildings, and they're transforming current buildings into more energy efficient systems. And in some, this is going to add up to a pretty profound impact. So to conclude, urgent action is needed to reduce greenhouse gas emissions in all aspects of our life in order to avoid catastrophic consequences of climate change. And the health sector is responsible for a substantial portion of carbon emissions in the United States, and we are absolutely obliged to mitigate our impact on the climate. If we are to first do no harm, this is absolutely involved in that, and we need to mitigate our impact on the world around us. As I mentioned, changes are needed at all levels of the health sector, as kind of demonstrated by the NHS, at the provider level, the hospital level, the health system, and the national level. But many of these steps are actionable now at the hospital and health system level, and I think we have a lot of room to improve here at Barnes and in the United States as well. Here are my references. I want to just thank quickly Dr. Steve Cheng and Dr. Dominique Costco as the program directors and mentors this year. Shout out to Srinivas Murthy, who's a leader in this field, who has helped me kind of craft my talk after cold emailing him about it. Thank you to Dr. Frazier, my co-chiefs, and Medicine House staff for a great year. And I'll hand it off to Dr. Sarah LoCoco.
All right, thank you, Jonah. That was very interesting. I think it'll be interesting how things go, I think, over the next couple of decades. So transitioning into my talk, again, my name is Sarah LoCoco. I will be, it's bittersweet. We're ending our chief year. It's been an exciting year, so I'm honored to be able to speak with you all, especially after being able to celebrate all the accomplishments yesterday of the House staff with faculty. So it's exciting to be here for Chief Grand Rounds. I think it's fitting to have it this week because I'll be talking about research that I've been doing with my mentor, Dr. May, the entirety of my residency. So I think it's fitting for this week. So my topic is man versus machine, the emergence of machine learning and differentiating wide QRS complex tachycardias. So a few objectives for my talk. We'll first review a few historical manual approaches to wide complex tachycardia differentiation. We'll then take a step back and define a few select concepts in machine learning. I'll then highlight a few examples of machine learning in medicine, particularly in cardiovascular care, with a special focus on our novel automated methods. And then I'll illustrate the comparison between the two, between the historical approaches and these novel methods. And then we'll consider a few future directions that we can see for how to use machine learning in this field. So I would be remiss to be talking about wide complex tachycardias without showing you an EKG. So quick question, can anyone diagnose these wide complexes? Pretty much a rhetorical question. So I'll show you a few. So you got this guy here, followed with this one here. Maybe you can diagnose it quickly, maybe not. But wouldn't it be nice if we had some help? Well, good thing we have a hero to save our day. It's machine learning. It's here. And it's very exciting as it's booming in medicine right now. But before we can talk about our hero, I want to talk a little bit about wide complex and how we differentiate them. So wide complex tachycardia is a cardiac rhythm that has a rapid ventricular rate of over 100 beats per minute and a prolonged QRS. When you think of how to differentiate it, you're simply thinking, is it VT or is it a supraventricular rhythm? Successful differentiation has undeniably led to important therapeutic and prognostic implications. So for instance, an accurate diagnosis leads to appropriate, high quality, cost-effective care for a patient. An inappropriate diagnosis, on the other hand, can lead to inappropriate clinical decisions, which can have adverse effects for our patients and even fatal outcomes. So what do I mean by all of that? So think, if a patient has an actual ventricular tachycardia that you misclassify as a supraventricular rhythm, it may lead to a medication administration that leads to hemodynamic collapse and catastrophic events for your patient. On the flip side, if you have an actual supraventricular rhythm that's misclassified as VT, it can lead to aggressive and expensive incorrect treatments. Maybe a patient's going to get an unnecessary external shock. Maybe they're triaged incorrectly and they go to the ICU. Maybe it even leads to invasive procedures that they don't need. Because of the importance of clinically diagnosing these and how it affects patient care, there have been decades of research that have been dedicated solely to looking at how to improve clinical diagnostic accuracy of wide complex tachycardias. Starting in the 60s, they started identifying morphological criteria that would help clinicians. Of note, in the 70s, Wellens noted AV dissociation, which I think a lot of us think when we think of VT. What I do want to note is in the 90s, Brugada took a step back, so we didn't focus solely on just these strict diagnostic criteria, and instead use diagnostic algorithms that clinicians could use to help better diagnose a few of these very tricky rhythms. I do highlight with the yellow arrows a few of these algorithms. There's frequent multi-step algorithms, there's point-based systems, there's even single criteria algorithms. And then with the pink arrow, I do want to highlight that this is the work of all of these algorithms has led to where we get an automated model. So looking a little bit closer at these multi-step algorithms, these are examples of manual methods. So Verrecki and Brugada did fantastic work with creating these. However, I do want to note that although they look simple, you follow an algorithm, you get a yes or no. What's important about these is that they're solely dependent on the ECG interpreter, solely dependent on the clinician being able to utilize these correctly. So this leads to where the limitation of manual approaches are. They can have time-consuming application that we may not have in the clinical setting. They had low reproducibility, meaning that the initial studies showed that these algorithms had really high sensitivity and specificity in diagnosing VT or a supraventricular rhythm. However, subsequent studies were not able to reproduce these great results. So most importantly, though, that I mentioned was just the dependence on the competency of the ECG interpreter. So it depends on the clinician, depends on who's using these algorithms to see if they're actually going to diagnose this correctly. So that's where our hero comes in. So Dr. May and his colleagues worked very hard to to challenge the reliance that we have on these manual methods, to challenge the reliance that we have on the competency of an ECG interpreter, to create automated models that take that factor away. But before I describe the automated models, I want to talk a little bit about machine learning. It's a concept that I had to learn quite a bit about over the past few years to understand truly what this is. So machine learning, unfortunately, is not how we learn. It's not in the classroom. Interestingly enough, machine learning has actually been around since the 50s. It was a term coined by Arthur Samuel, who was a computer scientist who, interestingly enough, was a big pioneer in machine learning and taught an early computer how to play checkers at IBM. But think of machine learning as this fusion of computer science and statistics that is used to address a problem, a question, a prediction. These are computer algorithms that learn from data. So they're learning patterns from the data that you give to them, rather than having rules that are explicitly programmed into them. From these learned patterns, a machine can then create complex analytical models that help refine and optimize its accuracy. So machine learning has been around for a long time, and it seems to be booming right now, but I do want to note that we are using it in our everyday practice already. This just represents a few examples of machine learning. So for instance, it's big in public health, which has been, very important over the past few years, in identifying outbreaks, tracking contacts. It's interestingly used a lot in image analysis as of right now, including things like detecting diabetic retinopathy from photographs. So two key concepts, though, from this that I want to explain about machine learning before we talk about the models are first, supervised machine learning. So supervised machine learning is something that incorporates pre-specified features that are either known or they're novel to achieve the desired task. So these features are selected by an expert and deliberately input into the computer. These features help create shorter model training times, and as well as make it easier to adapt to smaller data sets, but with a few drawbacks. Because we are pre-specifying features for the computer to use, there's more susceptibility to biases, and we also have this risk of omitting hidden features that we may not see as important. So to illustrate what this looks like, let's just think of a very simple example. So you want a computer to be able to predict what a shape is. So that means that you'll give it labeled data, you'll give features of what shapes are, and then you also give the label of what a shape is, but that's it. So these are the pre-specified features. The machine will then learn from what you give it. It'll create an algorithm in order to predict what it is. You will then validate its algorithm by giving it test data and seeing how it predicts it. The other concept, though, that I want to highlight is the idea of unsupervised learning, particularly deep learning. Deep learning learns high-level tasks without relying on these pre-specified or engineered features that experts choose. It does this via extensive neural networks, which think that it's trying to essentially imitate how the human brain interprets and draws conclusions from information that we're given. It can execute these tasks on very vast data sets, and it also can lead to these discovery of hidden features that we may not see as important, but also has its drawbacks. It can take longer to train these models. It has a higher overfitting risk, and it also can be more difficult to interpret and validate its data, leading to something called the black box, which I'll highlight in just a second. So another illustration of what this looks like. With a deep learning or unsupervised learning, you're giving the computer just raw data. There's no rhyme or reason to it. You have no known output for it, and it's not going to have any training set to then create an output. A lot of times this may cluster data, it may pool data, it's going to identify groups within the data. But this may have some drawbacks, overfitting. So overfitting being one of them. So overfitting is the mismatch between the complexity of an algorithm and the size of the training data set. So essentially, if an algorithm is too complex and the data set is small or too simple, it's going to just learn the noise of the random fluctuations. It's going to memorize rules about that then can't apply to other external data sets, to larger data sets. And another concern with deep learning is this idea of a black box. So with deep learning, it's difficult to maximize both the interpretability and the accuracy of it. This means that an algorithm may perform fantastically. You may get 99.9% accurate, but you have no idea how it got that. So for instance, with this picture, you can see that you have a correct answer, you have a correct prediction, but you have no idea what happened in that black box to get you there. And because of this, you have an inability to draw meaningful conclusions or explanations regarding how the model performed. So now that we know a little bit about deep learning, hopefully this joke kind of doesn't go over everybody's head. But talking a little bit about machine learning. So I highlighted this, these are current concepts that we're using, but it's also important to note that it is a booming field. It's been around for a long time, but with current technology. This is just a few examples from PubMed this week of what some AI and machine learning in the field of medicine. In cardiovascular care, it's important to note that over the past 5 to 7 years, there's been thousands of publications, most of them original work, that have been published and this is from PubMed. This is only halfway through 2020, but you can see probably by 2023, this has risen significantly. So it's something that we can't ignore. It's also interesting to note that, particularly with cardiovascular care, it makes sense that the data that cardiology uses is fit for something like this. We have EKG data, we have CTs, we have MRIs, we have ultrasounds that are perfect for this type of learning. And this is an example just from 2021, so it's probably needing update of just what we're using in real life. You may not even know. And what I want to highlight are things that we are using every day, our iPhones, our Apple Watches, everything that are utilizing computer algorithms to improve patient care. So back to cardiology and back to our heroes with wide complex tachycardia differentiation. So these are the 3 automated models that I'll be discussing. They are named the Wide Complex Tachycardia Formula, Formula 2, and VT Prediction Model. A little bit about these models is that they utilize features that were either selected or engineered by human experts. These features were either well-established VT predictors or they're mathematically formulated. The data was from readily and universally available from computerized ECG interpretation software, so things that we have here at Barnes. And they're derived from paired wide complex tachycardias and baseline ECGs. These models provide a VT probability estimation. So rather than getting a binary classification, is it VT, is it not VT, is it supraventricular, is it not? You get more of an estimation that you can then use with clinical features of your patients to help you decide what the actual rhythm is. And these features all use logistic regression modeling to do so. So a little bit about the specified features that these models use. They're based essentially on the underlying differences in how ventricular and supraventricular rhythms activate the ventricular myocardium. So if you think the supraventricular rhythms are typically more restricted to the baseline conduction pathways versus ventricular or VT is not, has more limitless or unrestricted ways in how it can depolarize the myocardium. A few names of these features that are used are change in QRS duration, change in QRS axis, frontal and horizontal percent amplitude change. It's a lot of words. What does that actually mean? So here's just a representation of what some of these mathematically formulated. On the left, you can see this is just a stereotypical QRS complex. And on the right, this is an example of what those mathematics that the algorithm is using to help it predict the rhythm. So similar to the other illustration I showed, this is more pertinent to our model. So we've showed the features, we see that they were modeled, they were derived, and they were validated. But how do you decide a model selection? Well, all of that, and then model selection leading to model implementation, well, that will depend on how the model performs. And the good thing is that these models actually perform quite well. So these are histograms that demonstrate the distribution of VT and supraventricular rhythms according to the automated methods. They give VT probability estimates. So essentially you can see that they performed quite well. And this highlights, again, just the diagnostic, the overall performance of these is quite high, which is very exciting. So we know that they work well. We know that there's historical basis for manual methods, but we don't know how they actually compare. Is it relevant? So we know that they can diagnose VT. We know that they can diagnose if it's not VT, but doesn't matter. Well, because of that, we decided to directly compare the two. So the work that I'm doing with Dr. May here is essentially directly comparing these automated methods with 3 manual methods. So we collected data from 213 ECGs from patients here at Barnes. We applied the 3 automated methods that I discussed, and then applied 3 manual methods, particularly Brugada, Gurecki AVR, and the VT score. These manual methods were performed by 2 electrophysiologists here at WashU. It was important to use electrophysiologists because we wanted to ensure that these were applied correctly. So why not ask an expert? So we don't have all the data yet, but preliminarily, we can see that the overall accuracy of the automated methods were either equal or superior to the manual methods. And then looking a little bit more broadly at other performance metrics, you can then see again that the automated methods performed either similarly or better than the manual methods. So preliminarily, we're concluding that these automated methods offer a viable alternative for accurate wide complex tachycardia differentiation due to their similar or superior diagnostic performance. Okay, we can see that they work, but what does this actually mean? How would we actually use this? Well, we're going to use it in things that we're already using. These are examples of GE products. So this is Muse on the left that we utilize here, as well as an ECG machine that I think some of you are probably going to use even today. So what would we actually do? So using these computer algorithms, when you get your ECG from the computer, rather than saying a wide complex tachycardia, it will then give you that VT probability estimation at the top, which you then can use in the clinical setting of your patient to help you decide what the rhythm is. But, so this is theory, it's fantastic, it's very exciting, but it's still, again, theory. It's not something that we can use right now. But I do have some good news, is that we do have our first clinical application of this. It is by the name of the Mayo Clinic VT calculator. And this is an example with its URL. So it is something that you could pull up right now. It's free. You don't even have to know anything about ECGs to be able to use it. You just need the baseline ECG of a patient as well as the wide rhythm. And you will simply input the standard ECG measurements into the calculator, and it'll give you that estimation. So this is great for, early learners that aren't sure, for clinicians that maybe don't have access to an electrophysiologist if they're concerned about a patient, which leads to further applications of how we can use this. So we can use it in our ECG machines, but it would even be more exciting if we use it in things like telemetry. The onset, offset of a lot of these rhythms are rapid, and we all know it takes a while to get an EKG on a patient. So it'd be great if we could input into telemetry so you could have it in real time when a rhythm happens for a patient. So who would benefit this? Like I said, medical trainees when they have limited experience, maybe an ER physician that's dealing with a lot of high acuity patients, a surgeon in the OR that's waiting for a cardiology consult. It's not used to, they don't have the same clinical experience that we do with these wide rhythms. And most importantly, our patients. I wanted to highlight that we want to focus on high quality, cost-effective care for our patients. And I think machine learning, especially methods like this, really do help that. So to end, I just want to talk about machine learning again in medicine and to highlight its importance. So this is a review article that's going to start an AI in medicine series with the New England Journal of Medicine. They'll be starting a review series. And their conclusion I really want to highlight. They say that health professionals will figure out how to work with AI and machine learning as we grow along with technology. AI and machine learning will not put health professionals out of business. Rather, they will make it possible for health professionals to do their jobs better and leave time for the human-to-human interactions that make medicine the rewarding profession we all value. And with that, I want to thank Dr. May, my mentor over the past few years. I'm excited to stay here and continue to work with you. A couple other shout outs would be Anthony at Mayo Clinic, as well as Dr. Cooper and Dr. Godbon for working with us on this study. Dr. Frazier, Dr. Costco, Dr. Chang, my co-chiefs, bittersweet moment. We're getting to the end, as well as our lovely residents and other colleagues at WashU and at Mayo Clinic.
Thank you both for those terrific talks. Jonah, come up. Sarah, we have time for a few questions. So maybe I'll start. Jonah, you talked about different interventions at a personal, hospital, national level. So do you want to reiterate what you think are the personal interventions that we could all take to heart to start making a difference?
Yeah, I mean, most of us probably already do some of these on our own outside of work. I mean, in terms of, recycling, trying to drive less, all of these types of things. I think we can apply some of those things that, in the hospital as well. But it is hard on an individual level to make substantial change. I mean, and so I do think there is an importance at the hospital level and above to implement sort of broader policies that make those formulary changes that I mentioned and broader changes as well. But, probably to a certain extent, if you do use, for example, meter dose inhalers that could be switched to dry powder formulations or things like that, those would be ways to start on an individual level.
Sarah, in addition to wide complex tachycardia, what do you think are the potential other machine learning applications for cardiology or other aspects of critical care?
Yeah, I think it's a great question. So like I highlighted, I think we have so much data with cardiology. I think we are continuously tracking patients, whether in the ICU, whether on the cardiology floors with telemetry, but with the use, I think particularly with imaging, so not with just EKGs, with the boom again of using CTs for patients, with the continued growth of ultrasound, I think that there is just unending possibility with what we can use and continue to perfect these algorithms to help our patients.
Yeah, so I think to kind of summarize the question, for the most part, substantial change in terms of limiting pollution and greenhouse gas emissions are going to come from a financial standpoint in terms of limiting cost from the healthcare perspective, or they're just going to be forced upon us. And in order to do that, a compelling financial argument is going to be needed. So does modeling exist that will project future costs as a result of climate change that might make the argument to make changes now? Those models do exist, and actually that's going to be the topic of Puya Julhar's talk next week. But to short snippet on that is that, I mean, there is going to be profound cost in the future as a result of climate change on a lot of levels, including mass migration, flooding, displacing people, as well as air pollution and heat waves that result in cardiovascular and pulmonary related admissions. I think, that said, that information is already out there and people don't seem to respond to that. So it's hard to know, at what point we're going to cross the threshold where that information is believable by enough people to make a profound change now. But that's a good question. I don't know of any modeling like that. And to be honest, the amount that's published about this topic is on the minimal side. But that is an interesting area that should probably be studied in order to translate changes now directly into dollars saved. Yeah, that's actually a great example of a very pragmatic. So the question is, are there, I guess, things that we could study now, prospectively and pragmatically to show that things we do maybe have little benefit in order to reduce our carbon footprint. Yeah, and one example that Dr. Buehler mentioned is infection prevention measures that may have limited evidence, but result in a lot of waste. I mean, and we all lived through the height of the COVID pandemic and went through endless numbers of gowns and gloves and masks that, we needed to use, but when extended across the board, it's unclear what the evidence behind, if somebody had MRSA in 1980, do they still need contact precautions, right? So absolutely, that's an area that we need to investigate for sure.
I was wondering if there was a threshold for like how you feel like a percentage life is whether it's not serious, like we're all getting these scenarios where the stop is like 60% or 50% can't see and I can tell you scenarios where a president is
Yeah, absolutely. So the way that we modeled it is we had a 50% cutoff for it being VT or not. So I think it's fair to say that there is going to be some nuance. The models themselves, we did not get any of the lower percentiles. With the manual methods, we did. We had accuracy in the 30% on some of the models that were used by electrophysiologists when they looked at the ECGs. So I think when you have a model, the importance is that you want to see that it can perform accurately. And so all of the models had either 80% or higher. We didn't have really any instances of it being this nuance in the 60s closest, or at 52%. So if it, and as I had a slide that showed those histograms that showed how the models performed, and they performed very well in seeing where the percentile of the probability, if it was actually VT or not, with an actual VT ECG. So you can see that they perform quite well. The important thing is actually using these in clinical settings and using these and seeing how they perform, since we know on the validated data that they perform well. So ideally, we would not get those instances where you have 52% that you have to decide, is this actually important? Because if an algorithm actually did that, then it wouldn't be useful, wouldn't be valuable to put the time, the effort, the cost into inputting these into how we do it. Because essentially, if you're getting something in the 50s and 60s, that's probably where your clinical suspicion already is saying, this might be VT, this might not be. Mm-hmm. Yeah, and I think that's the key question with machine learning in general, is when you finally get to a set of, okay, it's performing well on validated data, how is it actually going to perform in real life settings? So going back, probably part of the reason why the manual methods didn't work very well is they had limited patient populations. They took away patients that were on antiarrhythmics. They took away patients, that were sick, things like that, which clinically, these are not the patients that are going to be in these rhythms that we're taking care of, that we're not sure what's actually going on. So the good thing about this data is that we did not limit the patient populations. So I don't unfortunately have the numbers yet of what the patient characteristics look like, but we did not take away patients that were on any antiarrhythmic. It didn't matter what their EF was, didn't matter if it was non-ischemic, ischemic cardiomyopathy that caused these rhythms, which I think is really important. So we know that this can then apply to patients in real life setting. Yep. So what I will say is the data that we used for this study is I think it was maybe over 100 patients where those 213 ECGs came from, and they were from Barnes. So what I will say is that they are Barnes-specific patients, so we know this patient population racially is very localized to where it is. So I think that further would be next steps of seeing not just African-American patients, not just maybe Caucasian patients, but broadening it from there. Mhm. Yeah, absolutely. So what I will say is the way that these machines work is it's comparing a baseline rhythm of a patient to a wide complex. So the more different that the rhythm is from the baseline of a patient, the more likely and the better that it performs. So that's kind of what we can see clinically, is that if it looks significantly different, then our signals pop up and we're saying, hey, this is probably VT or something. But what was exciting is that we did have multiple ECGs from the same patients, as well as it was still performed very well on those that had a questionable diagnosis, that required EP studies, that required device recordings, required an electrophysiologist to make that diagnosis in the clinical setting. This patient population, the diagnosis was also made by EP studies. So it had this like gold standard, meaning that we were able to confirm with an EP study or with a device that it actually was VT versus having a clinician, whether it be a resident, whether it be a cardiologist, an electrophysiologist make the diagnosis. I hope that answers your question.
Thank you both very much.